thank you for the kind introduction, and I would like to thank the organizers for the kind invitation to participate in IVHEM again this year. And I'm only sorry that because of an unfortunate family emergency, I can't be there with you in person, but I will hopefully be able to join much of the conference virtually, and happy to give this presentation on new biomarkers and core antigen-based tests for hepatitis B. Here are my disclosures. So I'll firstly review the novel biomarkers that we use for hepatitis B and then discuss their current utility in terms of predicting disease activity, treatment response, and how they may be used to guide stopping antiviral therapy, and then talk about their future potential use. So first, let's make sure we all know what we're talking about. We have our classical hepatitis B biomarkers that we can measure in the blood, the surface antigen and e-antigen with their respective antibodies, as well as core antibody. And then we can directly measure hepatitis B DNA in the blood, as well as, of course, liver damage from the ALT. And we hope that these markers that we measure in the bloodstream are reflective of what's going on inside liver cells. Now, some of the novel biomarkers probably give us a little bit more insight into what's going on inside the hepatocytes. So we have quantitative surface antigen, and importantly, this can measure both intact viral particles or the subviral particles that don't contain any HBV DNA. Correlated antigen, which I'll talk about quite a bit, is a combination of three different components. So you can see a schematic of the processing of the core gene here, and the correlated antigen measures the core antigen, e-antigen, and the P22 subunit. And all three of these are combined into that measure of correlated antigen, whereas a new assay is now able to measure core antigen alone, as well as its phosphorylated version, and I'll talk about that at the end. In addition, we can directly measure hepatitis B RNA inside viral capsids in the blood. So these novel biomarkers probably actually add significantly to the complexity. And of course, I've said in jest that all of the, I think for many people, the existing serology already gives us a bit of chest pain to try to figure out what to use when. And I think it's important as we think about adopting these novel biomarkers that we make sure that they really do add value, because it's very unlikely they're going to simplify things. And we need to make sure that that added complexity is worth the effort. So first, before we go into their utility, let's make sure we understand what they actually are measuring. So hepatitis B RNA and correlated antigen are often lumped together, and this new core antigen assay is similar in that these are thought to reflect directly transcriptional activity of covalently closed circular or cccDNA. And the reason for that is that these, the viral RNA, pregenomic RNA, as well as the viral proteins, can only come off of the cccDNA. And this is in contrast to quantitative surface antigen I'll mention in a moment. Now, what's true is when these are positive, they clearly reflect active transcriptional activity of cccDNA, but sensitivity is an issue for both assays. And that means that a negative result here doesn't necessarily mean there's no cccDNA there. Now, quantitative surface antigen is an important measure, but it's important to recognize that it can come from two sources. So what we're interested usually in understanding is cccDNA-derived quantitative surface antigen. So you get transcription of the viral RNA and then translation to the viral proteins, the small, medium, and large surface antigen. However, this can also come off of HBV DNA that has integrated directly into the host genome. And if the surface antigen gene is in frame, then you get exactly the same pathway of transcription of the viral DNA from the host genome to make those same viral transcripts and the same host proteins. And the challenge is that there's no real easy way to distinguish the source of surface antigen, but as I'll show you in a minute, it might actually be very relevant for a person with chronic infection. So let's think about how we can use these tools. So the first question is, can they help us identify the phase of disease that someone's in, going from immune tolerance to immune active disease. And then after E seroconversion, people may either stay in the inactive carrier phase with lower undetectable HBV DNA and normal liver tests, or they may have repeated bouts of active chronic hepatitis, so-called e-antigen negative chronic hepatitis B. And when we see someone here, we don't know whether this person has prolonged inactive disease or is between two flares of chronic e-antigen hepatitis. And of course, this is important because we would observe the inactive carrier, whereas we would likely treat someone who is going to have repeated flares of disease. So can these new markers actually help us distinguish this? Well, if you take people with low levels of HBV DNA and you then look at their quantitative surface antigen level in this study from Taiwan, they found that patients with a surface antigen level below 1,000 IU per ml were less likely to develop e-antigen negative hepatitis, and more importantly, we're less likely to go on to develop cirrhosis. So this could be used in combination with our current markers for inactive disease of liver enzymes and HBV DNA to predict a very low risk of future disease. Now, importantly, there still was some risk of both active hepatitis and even complications like cirrhosis and cancer, meaning that even for inactive carriers, long-term follow-up is clearly required. Another study from Europe showed very similar results with very good predictive accuracy of being an inactive carrier and negative predictive value for future active disease. So this has led to the proposed paradigms like this, where you take the HBV DNA, if it's low with normal liver tests, you then could use the quantitative surface antigen level, and if it's very low, have good confidence this person is going to have inactive disease, certainly in the short term, which could help guide, at least at the minimum, your follow-up interval for patients in this setting, which has some practical application. So what about some of the other markers? Well, as you might expect, correlated antigen, you can see through the different phases of disease, and where you see very high viral replication, like in the immune tolerant phase, high levels of correlated antigen, and as replication drops off, so do the levels of correlated antigen, such that inactive carriers have low or often undetectable levels of correlated antigen in the blood. And if you look at these two assays together, correlated antigen and surface antigen, you can see that in certain phases of the disease, you can see that they correlate very well. But you can see that in inactive carriers, you can see that in part of some of the patients, they correlate well here, whereas there are other patients who have undetectable correlated antigen, but still have very clearly detectable surface antigen levels. So you see, you might anticipate that there's good correlation here when surface antigen is being derived from cccDNA, whereas in these patients who are still surface positive but have undetectable correlated antigen, maybe all of that surface antigen is coming off of only integrated DNA. And in fact, this person could have effectively achieved a functional cure already, but remained surface antigen positive. This is important because it's sort of giving us a false negative for our functional cure, and leading us to tell this person that they still have active replication when they may indeed not. And so this is an important consideration. Now, what about if you add correlated antigen to surface antigen to try to predict inactive disease? And in this study from Europe, they found that if you took patients with a low surface antigen level and then added in a lower undetectable correlated antigen, you got very good sensitivity and specificity for predicting long-term inactive carriers. Whereas if you use surface antigen alone, you can see that the sensitivity particularly dropped off significantly. Now, notably, although this study looked very promising, conflicting data from another study in North America give us some uncertainty about the utility of this assay. Now, I mentioned that there's a lot of new therapies coming down the pipeline for HBV cure. We hope we're going to be able to cure this infection soon with lots of different viral targets. And here the novel biomarkers are really important. They can confirm target engagement, tell us that the drug is doing what we think it's doing, or potentially clarify novel mechanisms of action for some of the newer agents. They may provide surrogate responses or even potential clinical endpoints. So if you take these different assays and you think about how they may play out along these different aspects, we can see that quantitative surface antigen has probably some utility in identifying inactive disease, and at least in some studies, correlated antigen adds value here, but a bit of conflicting data, and HBV RNA has been less well studied. Now, when you look at treatment response, quantitative surface antigen levels have very good stopping rules if you're using interferon-based therapy, but not so helpful with the more common scenario of nucleoside analog treatment. And these other agents have been less well studied and probably less useful. Now, where they may be most useful is in terms of predicting who can safely stop nucleoside analog therapy. For Asian populations, you have to get to a lower level of surface antigen, probably below 100, to safely consider stopping, whereas in non-Asian patients, that may be able to go up to 1,000, and patients can safely stop. Now, in this small group of patients that fall between 10 and 100, the correlated antigen, at least in one study, provided a predictive value. If it was negative, they were less likely to have active disease. In patients with positive correlated antigen, they may want to continue therapy. And HBV RNA also can be helpful in some studies, but probably not absolutely critical. Now, when we look at the newer agents, I've mentioned that these newer correlated antigen, HBV RNA, are particularly useful, whereas for surface antigen, we don't know the source of it, so it's a little less valuable. But if you combine these agents, these biomarkers together, we might be able to define something like a partial cure where someone may remain surface antigen positive but has a low likelihood of active disease in the future, and this could be quite useful. So to summarize, the challenge with quantitative surface antigen is we don't know the source being integrated or cccDNA. It's still measured in a central lab, but it is relatively standard serology and could be fairly inexpensive. Both of these new assays reflect cccDNA activity only, but they have a problem with sensitivity, and with HBV RNA, it's both not well standardized across assays, and it's also nucleic acid, so tends to cost more money and be a little bit less stable for storage. But these assays are also, probably most concerningly, not widely available outside of high-income settings, making them of limited clinical utility currently. Now, I mentioned this newer assay, HBV core antigen, which directly measures both the phosphorylated version of core antigen as well as the unphosphorylated form. And this comes, again, only off of cccDNA transcription. Now, you can see that the two forms, phosphorylated and unphosphorylated, correlate well, with phosphorylated levels being produced at higher levels. But again, sensitivity becomes an issue here. You can see that when you look for both of these assays, you've got to have between 5 and 6 logs of HBV DNA to be able to measure the core antigen, whether the phosphorylated or unphosphorylated form. Now, this is an intentionally complicated figure of a patients being followed on tenofovir, followed by the addition of interferon, followed by nucleic acid polymer. But what I want to highlight here is how these different versions of core antigen track. And you can see that the unphosphorylated version of core antigen in black correlates very well with HBV DNA, goes down nicely as DNA is suppressed, and rebounds fairly quickly as DNA rebounds with stopping therapy. Whereas you can see that the phosphorylated form of core antigen here in blue tracks almost perfectly with correlated antigen HBV RNA. So with this assay, you're now getting sort of both of these things, so the correlated antigen and RNA, as well as a direct measure of DNA using a serological assay. So if you compare correlated antigen to core antigen, the problem with correlated antigen is really that it's not specific. It's measuring all three of these things, e antigen, core antigen, and the P22 subunit, which is particularly problematic in e antigen positive disease, where it's really not very useful, whereas the core antigen doesn't cross-react there, so more useful with e antigen positive disease. Both of them do measure cccDNA transcriptional activity, and sensitivity is clearly an issue for both, but perhaps the most relevant difference is the correlated antigen does not track with HBV DNA, whereas the unphosphorylated version of core antigen tracks very well with HBV DNA. And so this could effectively give us a serological test for HBV DNA, which is at least potentially cheaper and more stable than HBV DNA. Might still be hard to make it point of care, but it's potentially possible. And this could be an important advance for management of HBV in low and middle income countries, where you can imagine a simple paradigm of someone having a point of care test for surface antigen, and then while guidelines typically recommend HBV DNA, maybe this could be replaced by a simple serology of core antigen, which hopefully would be more widely available, some testing, and then the patient goes on therapy. And again, you could potentially use this assay to follow someone during treatment. So this paradigm would obviously have to be demonstrated, but I think it does give us some interest in further exploring this marker. So to summarize, novel HBV markers have some, but I would argue limited utility currently, and may actually add to complexity rather than simplify things, which is why their role in low and middle income countries currently is very limited, if any. But I do think they have a very very important role for the curative therapies, the HBV cure strategies, to understand how these new agents are working. And I think this new HBV core antigen test may be quite useful as a potential proxy for HBV DNA using a serological test, which could hold great promise for a simplified, cheaper tool for low and middle income countries. Although I think it's important to remember that we may actually have to convince the manufacturers to develop it because it's got less clear utility in settings where HBV DNA is already available. And with that, I thank you for your attention.